Hello, my name is Susan Bourgeois, and today I will be working with my partner, Mark Torres. We are going to be discussing the pharmacology and current evidence on the administration of ginger for the treatment of postoperative nausea and vomiting. Above, we have listed a review of our objectives, and you can review them on your own time. We will start off with a brief review on the physiology of nausea and vomiting. You may recall that there are two forms of activation of the emetic center. Centrally, the chemoreceptor trigger zone, also known as the CRTZ, is located in the area postrema, and this connects to the vomiting center located in the medulla oblongata. The CRTZ receptors are activated by agonism of the following receptors: serotonin, also known as 5-HT3 receptor, dopamine, histamine, and opioid. Peripherally, nausea and vomiting can be stimulated via afferent nerve fibers along the vagus nerve. Above is a really nice detailed depiction of the physiologic mechanism of nausea and vomiting, and shows how the emetic center and CRTZ are stimulated. As you can see, the CRTZ is located in the area postrema with specific agonist sites for serotonin, histamine, muscarinic, as well as dopamine receptors. Additionally, the figure shows that the vagus nerve activates the emetic center when stimulated by GI tract distension, pharyngeal receptors, and input from other sensory areas such as vision as well as taste. Now we will move on to a quick overview on the common risk factors that can induce postoperative nausea and vomiting. They can be divided into two categories: patient and surgery/anesthetic specific indicators. Patient-specific indicators include patients who do not smoke, female gender, younger populations under the age of 50, pediatrics, a history of post-op nausea, vomiting, or motion sickness, gastric reflux disease, and patients with gastroparesis. Longer surgeries are also associated with higher rates of post-op nausea, vomiting, presumed to be related to the increase in the cumulative dose of inhalation volatiles and opioids received. Laparoscopic, gynecological, abdominal surgeries are also considered high risk for postoperative nausea and vomiting.
Ginger root, also known as Zingiber officinale, is a very common herbal root that's been traditionally used by ancient Chinese and Indian civilizations as a remedy for gastrointestinal disturbances such as nausea and vomiting. Ginger is generally regarded as a safe, non-pharmacologic supplement with a minimal side effect profile. As a crude herbal supplement or cooking ingredient, ginger comes in many forms including fresh ginger root or as a dried powder. Ginger contains three main bioactive ingredients: gingerols and show gels along with their subtypes, and galanolactone. Yamahara and colleagues isolated 6, 8, and 10 gingerol from the bioactive component gingerol and measured the activity of these subtypes on guinea pig ileum. The guinea pig ileum was used for this experiment because this tissue has a high level of 5-HT3 receptor expression. They were able to measure the activity of the gingerol subtypes. Specifically, the researchers tested the contractile strength of the tissue in response to serotonin, and then measured the response of the tissue to serotonin in the presence of gingerols. Similar research by Huang and colleagues helped to identify the 5-HT3 receptor as the primary receptor subtype. Subsequently, Wallstaff and colleagues demonstrated the non-competitive inhibition produced by these compounds in human tissue. These independent studies suggest that ginger acts primarily through non-competitive antagonism of serotonin at the 5-HT3 receptors found centrally in the CRTZ and peripherally in the intestines.
The pharmacokinetics of ginger has primarily been examined using dry powdered ginger in capsules. Yu et al. Examined the metabolism of ginger in participants receiving 2 grams of powdered ginger capsule in both single dose and multi-dose. The study found that participants consuming a single dose of ginger had gingerol and show gels plasma concentrations, which are the 2 most bioactive compounds in ginger, peak at 1 hour. Furthermore, they were not detectable after 4 hours. In the multi-dose groups, free gingerols and show gels were not detected in the plasma concentration 24 hours after consumption. This is presumably due to the short half-lives of these bioactive components. From these findings, it is suggested that the peak concentration of ginger occurs 1 hour after ingestion, and the half life of ginger is 1 to 3 hours after ingestion. Although the site of metabolism is unknown, metabolism of ginger is thought to be conjugated into glucuronide and sulfate metabolites prior to excretion.
The Food and Drug Administration recommends no more than 4,000 milligrams of ginger per day. Current research examining ginger as a treatment for postoperative nausea and vomiting is limited to 1,000 milligrams per day. This wide therapeutic index suggests that there is room to test higher doses of ginger, as its antiemetic effects are hypothesized to be dose dependent.
Side effects of ginger include mild gastrointestinal side effects, such as heartburn, stomach discomfort, and nausea, typically a safe and low side effect profile. Ginger is also known to increase bleeding time. These antiplatelet effects, which may increase the risk of bleeding, is mostly a concern for patients on anticoagulants or undergoing chemotherapy. In a recent study examining this theorized increased bleeding time, Marks et al. Proposed the mechanism of this effect is due to the interaction with arachidonic acid and inhibition of thromboxane synthesis in vitro. However, there is no clear-cut evidence of this effect in human clinical trials. Marks et al. Observed patients receiving ginger doses between 1 gram to 40 grams a day. They concluded daily ginger ingestion below 5 grams does not affect platelet activity. As we recall from the previous slide, the maximum FDA recommended dose for ginger is 40 grams or 4,000 milligrams a day.
The preparation and storage of ginger can alter its bioactive composition. For example, gingerols are converted to show gel when ginger is dehydrated. This can cause variation amongst different preparations of ginger, altering their supplement's efficacy and making it difficult to standardize the preparations. A study by Schwerner and colleagues examined 10 brands of ginger supplements and their chemical composition. They used high-performance liquid chromatography to analyze the samples. The results showed a wide variation in total recommended dosing, as well as concentrations of the active ingredients. For example, 6-gingerol was found to vary considerably, ranging from none to 9.4 per gram of ginger powder. Another brand was found to have extracts containing an average of 4.8 milligrams of gingerol and 10.2 milligrams of show gel as compared to their written standard of 20 milligrams for both compounds. Schwertner and colleagues suggested that this may be a result of processing and storage, which indicates the difficulty of standardizing ginger preparations for both commercial use and clinical trials.
The following slides will briefly look at the use of ginger in special populations. Currently, ginger is recommended as a first-line non-pharmacologic treatment for pregnancy, nausea, and vomiting by the American College of Obstetric and Gynecologists. Current research suggests ginger's ability to treat pregnancy-induced nausea and vomiting is of equal efficacy to vitamin B6, metoclopramide, and dimenhydrinate. Overall, ACOG recommends that 250 milligrams of ginger capsules be taken 4 times a day as an initial treatment before proceeding to medications such as vitamin B6 or dimenhydrinate. There is also no research suggesting that complications like stillbirth, malformations, and spontaneous abortions are increased with the use of ginger. Ginger has been utilized in patients undergoing chemotherapy. Chemotherapy-induced nausea and vomiting is an extremely unpleasant and common side effect of chemotherapy. Ginger has been studied as successfully treating nausea and vomiting in agents such as cyclophosphamide, anthracycline, doxorubicin, 5-FU, and cisplatin in lower doses. A 2003 double-blind study evaluated the ability of ginger to reduce chemotherapy-induced nausea and vomiting. They pooled 50 patients receiving 500 to 1,000 milligrams of cyclophosphamide. Patients were randomly assigned into 3 groups, and 20 minutes prior to chemotherapy, patients received one of the following treatments: either 2 capsules containing 500 milligrams of ginger and 2 mLs of intravenous normal saline as placebo, 2 capsules of lactulose oral placebo, and 20 milligrams of intravenous metoclopramide, or 2 capsules of lactulose, again the oral placebo, and 4 milligrams of intravenous ondansetron. The study concluded that a resolution to nausea and vomiting was found in 68% of patients receiving ginger, 64% of patients receiving metoclopramide, and 86% with ondansetron. These findings suggest that although ondansetron provided more relief than ginger, ginger's efficacy is still comparable to that of traditionally used antiemetic agents like metoclopramide.
Postoperative nausea and vomiting is one of the most common and uncomfortable side effects of surgery. It's defined as nausea or vomiting occurring within 24 hours during the postoperative period. Research examining ginger for the prevention and treatment of postoperative nausea and vomiting has mostly been studied in obstetric, gynecologic, and laparoscopic abdominal surgery. In many of these studies, ginger pills containing dry ginger powder were given by mouth 1 hour prior to surgery. Recent evidence suggests that ginger is effective in reducing postoperative nausea and vomiting. Meta-analysis by Todt and colleagues included 10 studies which investigated the effectiveness of ginger in a variety of surgical cases, but primarily in laparoscopic OBGYN surgeries, as this surgical population has the highest risk. The studies used fresh ginger, ginger extract, or ginger powder, and doses of ginger ranged from 100 milligrams to 1,000 milligrams. Analysis of the data showed that ginger is effective in reducing the severity of postoperative nausea and vomiting in patients reporting their level of nausea on a 10-point visual analog scale. Studies which used at least 1,000 milligrams suggest a statistically significant improvement over placebo, while studies using less than 1,000 milligrams showed no statistical difference with placebo. For example, independent studies conducted by Eberhardt and Talvin showed no statistically significant difference in nausea and vomiting as compared to placebo. However, these two studies used 600 milligrams and 500 milligrams of ginger respectively, which is way below the current recommendation of 1,000 milligrams. Current evidence suggests that the antiemetic effects of ginger may be stronger with doses of at least 1,000 milligrams, owing to the dose-dependent inhibition of the 5-HT3 receptors. Additionally, there is a small but growing body of evidence which examines the effectiveness of ginger in other types of surgery. For example, randomized controlled trials by Hosseini and colleagues found that patients who used ginger essence for open or laparoscopic nephrectomies had lower severity of nausea compared to those on placebo. Similarly, Montazeri and colleagues examined patients undergoing orthopedic, urologic, ENT, and abdominal surgery. They reported lower nausea scores in patients who used ginger preoperatively, regardless of surgical procedure. From the available literature, ginger appears to be a safe, low-cost, and effective adjunct for the prevention and treatment of postoperative nausea and vomiting. Further research should be conducted about the timing of ginger administration, method of delivery, synergy with other medications, and its dosing.
Below are our listed references. Thank you so much for listening in. We appreciate your time.